This part of the renal lecture will actually focus on renal failure and the sequela from that. We'll look at the causes, the symptoms, and the management of renal failure in patients. Acute renal failure can be divided into three different categories. Pre-renal failure, which is about 55% of all renal failure patients, where there is some sort of hypoperfusion to the kidney. So in other words, some sort of volume depletion, maybe due to decreased cardiac output or vascular failure. Also could be due to shock, decreased blood flow to the kidneys, due to perhaps a MI, CHF, sepsis, or anaphylactic reaction. Intrarenal failure is where there is damage to the glomeruli and tubules, and this accounts for about 40% of all renal failure patients. So in other words, there's actually necrosis of the renal tubular system, nephrotoxicity, and altered blood flow. It's decreased to the kidneys. And then there's post-renal failure, and this is about less than 5% of all renal failure causes. And this is due to some sort of obstruction between the kidney and the urethral meatus. So it could be due to some sort of an obstruction, such as from benign prostatic hypertrophy, which is BPH, or it could be due to kidney stones, a bladder tumor, injury, that type of a thing. So remember, the patient in renal failure, the patient's kidneys will not be able to remove the metabolic waste or perform all those regulatory functions that the kidney normally forms or performs. So typically about 50,000 people in the United States die each year from renal failure. And common symptoms are oliguria, which is less than 400 milliliters of urine produced per day. This is most commonly seen. The patient may also have anuria. Some patients, believe it or not, will actually have normal output, but they won't have, the waste will not be excreted as they should be. Patients typically will also have an elevated BUN and creatinine levels. Some stats that show the prevalence of renal failure: about 5% of all hospitalized patients will develop acute renal failure, and 30% of all patients that are in an ICU or critical care setting will develop acute renal failure. The mortality rate from acute renal failure is about 75%, and part of that is due to the fact that it tends to affect a lot of patients that are critically ill or the elderly, so they have a harder time when it does hit. So remember that the kidneys they get about 25% of the cardiac output to maintain glomerular function. If this gets reduced to even like 20%, it can cause decreases in the glomerular filtration rate, and it can also cause nephron damage. This picture is just a nice depiction of the differences between renal failure caused by a pre-renal problem, an intrarenal problem, or a post-renal problem. So just shows a picture of what we discussed in the last slide. Remember, the patient that is in renal failure can have problems listed on the right. That unhealthy kidney will lead to fluid overload, elevated waste products in the blood such as urea, creatinine, and potassium, and changes in hormone levels that control blood pressure, making red blood cells, and the uptake of calcium. So those will be the difficulties that those patients will face. The onset phase of acute renal failure is sometimes known as phase 1. Your particular textbook refers to it as the initiation phase. Begins with the initial symptoms and that the patient experiences, and typically when we think about this phase will last hours to days. So for any time a patient experiences ischemia over 2 hours or more, where the kidneys have a decreased blood supply, this can actually cause severe and irreversible damage to the kidney tubules. So also common nephrotoxins can cause damage to those tubules. So certain medications such as aminoglycosides, radiological contrast medium, NSAIDs, some chemo drugs, and some rheumatoid arthritis types of meds such as some of the heavy metals and mercury and gold products can cause nephrotoxicity. toxic problems. The next phase of acute kidney failure is called the oliguric phase. This is phase 2. Your textbook refers to this as the maintenance phase. This is where decreased glomerular filtration rate and tubular necrosis will occur. So upon assessment, that patient will have edema, heart failure, neck vein distension, or jugular vein distension, same thing, weight gain, crackles in the lungs, and a decreased urine output. So it's very important to make sure that the patient's cardiac rhythm is monitored in this particular case scenario. And remember that some clients will actually have normal amounts of urine even though they are technically in this oliguric phase. Most clients have oliguria, but some patients, as we said, will have normal amounts, and this is called non-oliguric acute renal failure. And remember, in this phase, the kidney's not eliminating waste products, even if it is producing urine. So that's why you see these symptoms of fluid retention, azotemia, metabolic acidosis, and electrolyte changes on these patients. The problem that they have in this oliguric phase is they can't regulate their electrolytes, and upon assessment, you'll notice that these patients have elevated potassium levels, elevated magnesium, elevated phosphate, and low calcium levels. Another problem is that they're not able to excrete waste products into the urine, so it can be excreted from the body. So you will see elevations in BUN and creatinine levels, which can lead to azotemia, and you'll see metabolic acidosis because the diminished ability of the kidneys to eliminate the hydrogen ions and to regenerate bicarbonate products. The other thing that's going on is the patients have hematological dysfunction. Anemia occurs because of the decreased ability of the kidneys to produce erythropoietin, which is necessary, remember, for red blood cell production. And also platelets don't survive well in a toxic environment, so then there's decreased coagulation and problems with bleeding because of that. So management during this phase would be to avoid foods that contribute to the hyperkalemia problem. Glucose and insulin to treat hyperkalemia. Remember in the diabetes lecture we talked about insulin drips and how that will help to reverse hyperkalemia. Look for EKG changes due to the elevated potassium levels in the body. Treat the patient for acidosis. Patient will more than likely need dialysis, fluid restrictions, and perhaps low-dose dopamine to increase renal perfusion. Remember, at low doses, dopamine is for renal perfusion. At higher levels, dopamine then affects blood pressure. Kayexalate may be used to treat hyperkalemia to bring down those potassium levels, and the patient may also be given phosphate binding agents. Lasix for the edema, and typical diet for these patients is going to be one low in protein, low in potassium, and low in sodium. High carbs is okay, and the patient may need TPN for adequate nutrition. Phase 3, or the diuretic phase of acute renal failure, is where the nephrons are beginning to recover, but they're not quite yet at full capacity. So the patient still has some fluid imbalances and still has some electrolyte issues. And problems with this is the patient's going to have increased urine output and potential for dehydration. So look for hypovolemia, hypotension, and dehydration as that kidney starts to heal, and watch for weight loss, dry mucous membranes, and decreased skin turgor as a result of dehydration. In that diuretic phase, the lab imbalances are going to continue. The patient will lose sodium and potassium, but the BUN should slowly start to decrease and get back to a baseline, relatively normal value. Watch fluid and electrolytes on these patients, and also limit fluid restrictions to prevent dehydration, and monitor lab values. The recovery phase is considered phase 4 of acute renal failure. The kidneys start to return to normal. The residual renal insufficiency should be repairing itself. The patient will still have decreased energy levels, And remember, this phase can take anywhere from 3 to 12 months to have that patient's kidney function return back to normal. And remember, some patients will never have kidney function get all the way back to normal if they've experienced acute renal failure. For those patients that have chronic renal failure, it's considered that they have about less than 10% of their nephrons still in a functioning state. Some common causes of chronic renal failure include glomerular nephritis, polycystic kidney disease, diabetes, and hypertension. The patient will go through different stages where there's a decreased kidney reserve, kidney insufficiency, kidney failure, and then the patient will go into end-stage renal disease. And the clinical manifestations this patient will have, symptoms will include uremia, which is actually the actual translation of that is urine in the blood. The patient will have nausea, apathy, fatigue, weakness. The patient will also have decreased immune function. They may have GI symptoms and bleeding, neuro changes, muscular changes, decreased reproduction function, and endocrine changes. So because of that kidney renal failure, the patient will have changes throughout the body. Diagnostic tests that support renal failure would be elevated BUN and creatinine, decreased creatinine clearance levels, elevated sodium levels, elevated potassium levels, decreased calcium levels, increased phosphorus levels. Magnesium will be increased. pH is typically going to be acidotic, so decreased. Bicarb will be decreased. H&H will be down, and uric acid levels may be increased with this particular scenario. Medication management is going to include to give the patient epigen for anemia to stimulate red blood cell production, put the patient on ACE inhibitors to bring down the blood pressure, and phosphate binders to bring down those phosphate levels, Kxalate enemas to bring down potassium levels, or remember we talked about that insulin drip would also help bring down potassium levels. Patient may be given calcitrol for vitamin D, and folic acid for anemia, and Tums for hypocalcemia. So remember, there's always that risk of GI bleeding due to stress on the body, so they may also need to be on medications such as Prilosec or Zantac for the potential risk of GI bleeding. It's important to also maintain fluid and electrolyte balances, so look at the I and O balance, make sure the patient is weighed daily, assess for edema, breath sounds, vital signs, and LOC to check for changes with electrolytes and fluids there. And patients are typically put on fluid restrictions. A common practice is to do the previous day's urine output plus 500 to 600 mLs, and that's all that patient will be allowed for the next 24 hours. So that's one way to try and maintain fluid and electrolyte balance. Typically, patients are limited on protein in the diet, 1 gram per kilogram per day. Of course, potassium and phosphate foods are decreased, sodium foods are decreased. So examples of potassium and phosphate foods that need to be lowered would be bananas, citrus fruits and juices, coffee, those types of things. Patients are at risk for infection, so make sure they get good skin care, activity as tolerated, watch for those neuro changes and confusion, watch for exposure to infections. They're going to be at high risk to pick up infections. Avoid aspirin products because of the bleeding tendencies, and use a soft toothbrush for that. Make sure the patient is also comfortable, so make sure the patient has pain medications as needed. We can use antipyretics for the itching from the azotemia, emollient baths, keep the skin moist, control the temp, and try to have a very supportive atmosphere for that patient in renal failure. Remember that coping for the patient and family is going to be very difficult, so try to get them into social services and counseling and community resources to help for that patient that is in end-stage renal disease. And there's a nice nursing care plan in your book to look at regarding ESRD. For that patient that is in end-stage renal disease, these patients typically will need to go through some sort of dialysis, whether that be hemodialysis or peritoneal dialysis. The first one that we're going to talk about is hemodialysis. The patient will need a shunt or fistula in order to access hemodialysis, so catheter care is going to be an educational piece to go over with them. Certain medications will need to be held prior to hemodialysis. So make sure that the patient has a list from their physician what meds they can take and what meds should be held, because some of the meds can be dialyzed out, and so the patient wouldn't receive effects from them. So the patient needs to know, if they need to hold their cardiac meds and that type of a thing. Also, the patients are at risk for hypotension. So with the fluid removal that happens with hemodialysis, so keep a close eye on what their blood pressure is doing. Remember that hemodialysis will move the fluid and particles across a semi-permeable membrane, and by doing this it can help to remove the toxins, but it does not remove like the red blood cells or protein out, things like that. So, and that's because of the tendency of the way that the membrane is. Make sure that these patients also that we watch for something called dialysis disequilibrium syndrome, and that's due to cerebral fluid shifts. So symptoms the patient may have if they experience this include headache, nausea, vomiting, restlessness, decreased level of consciousness, and perhaps even seizures. If the patient does have this, the physician needs to be notified, and the patient may need to be changed to have dialysis for shorter periods of time, but maybe more frequently. So typically most patients getting hemodialysis will have that done about 3 times a week for a 3 to 4 hour period of time for each session. And this next picture just shows an example of how the patient is hooked up through their fistula to the machine, the hemodialyzer, which actually does all the filtering to take the toxins out of the body, so that the patient does not have the increased level of toxins staying in the system. Another option for these patients would be peritoneal dialysis, and with this it's also used to treat renal failure and acute and chronic renal failure. And this involves instilling a dialyzing fluid into the peritoneal cavity. So the patient will need to have a Tenkoff catheter in place into the abdomen, and then the peritoneum is what actually serves as the dialyzing membrane. So some patients prefer this over hemodialysis because they can do it in the comfort of their own home. They'll have that, like I said, that catheter in their abdomen that will need to be cared for. And they also will need to watch out for certain medications. But the patient typically will be able to do this on their own or have a home health care nurse come in and help them if they're not able to do it. And basically the nurse will use aseptic technique when using that, infusing the fluid through the Tenkoff catheter, and the nurse will note the fill time, the dwell time, and the drain time for the dialysis fluid. So complications from this can include peritonitis, perforation, and catheter-related issues. Typically, it's been said that peritoneal dialysis takes about 36 to 48 hours total to achieve what hemodialysis can done in 6 to 8 hours. Typically, patients will have very frequent sessions that are about 1 to 4 hours long as they do these, so they'll have to have that happen more often than if they were going in for hemodialysis. So the bags are weighed for intake and output, and that way the patient can determine how much fluid they actually pulled off and that type of a thing. There is an intermittent type of peritoneal dialysis versus a continuous, and most patients in the home setting will be on an intermittent type of a dialysis routine. For those patients that are not hemodynamically stable, for example, patients in an ICU setting and that could not handle the changes in their hemodynamics through hemodialysis, continuous renal replacement therapy may be an option for these patients. This only causes minimal volume depletions The hypotension is not as severe as with hemodialysis, and these patients typically have a gradual fluid and solute removal over like a 12-hour period of time or so. So for those patients that maybe are in heart failure or have been in a multiple trauma or had surgery where their cardiovascular system is not stable, this might be a good option for these particular patients. And this just shows you an example of what one of those machines looks like. Nurses that perform hemodialysis or CCRT are specially trained over several weeks to learn how to monitor patients and how to hook patients up and regulate these types of machines for these treatments. Another option for a patient in chronic renal failure or end-stage renal disease would be for the patient to get a kidney transplant done. The kidney can come from a living or a cadaver donor. It's actually an advantage is that there's an increased probability of living longer with having a kidney transplant versus having hemodialysis done. It was interesting that the probability of living 5 years after a transplant is 81% if the patient has had a kidney transplant versus only 32% if the patient's been on hemodialysis for 5 years. After 2 years of being on hemodialysis, the probability of living is 63% versus if the patient had a kidney transplant, the probability the patient would still be alive 2 years after having a kidney transplant would be 92%. So patients have a much higher chance of living after a kidney transplant than having to be on hemodialysis for years and years. It's also about 1/3 the cost to have a transplant done versus to have that patient stay on continuous dialysis. The problem, of course, as we all know, is that there's not enough kidneys for all the people that need them. In 2004, 16,000 patients received a kidney transplant. However, there were 62,000 patients that were still on the waiting list that were awaiting a kidney and never received one. The other risks is that that patient will need to be on immunosuppressant drugs such as Imuran, cyclosporin, or prednisone, and these drugs will suppress the portion of the immune system and inflammatory response, so it puts that patient more at risk for for infections and cancers with long-term use. The other thing is that transplanted patient may develop rejection of the kidney at any time. This could happen within hours of having the kidney transplant up to years later after having the kidney transplant. And symptoms that patient would have if they are rejecting the kidney would be oliguria, edema, fever, hypertension, weight gain, swelling and tenderness over the graft site, and elevated creatinine levels. So there's a great care plan in your book you can look at that talks about kidney transplants. The last thing we're going to talk about with renal issues are cancers of the renal system. They really don't, it's not a high proportion of cancers that we see in U.S. Probably only about 2% of all cancers that patients have in the United States are from renal source. The incidence is higher in men than women, and typical symptoms include hematuria, pain, and a mass noted in the flank area. Bladder cancer is more common in men than women and has a very close association with cigarette smoking. So typically symptoms with bladder cancer is that the patient has visible, painless hematuria, and treatment typically includes a cystectomy, which is removal of the bladder, chemotherapy, radiation, and also perhaps a topical chemo into the bladder. So depending on if the bladder needs removed is going to depend on the grade and the stage of the tumor that the patient has. So anytime patients have cancers of these areas, remember that urinary diversion device procedures like an ileoconduit are potential for that patient. So that's where they transplant the ureters to the sigmoid or jejunum area, and then the patient would urinate in this method. So There's a lot of tables and pages and care plans reviewing this content in your book that you can look at. So since you will probably take care of patients that have ileoconduits, make sure you review that content. This particular lecture doesn't have an NCLEX question, but rather just some critical thinking questions at the end to make you think back over the content. So make sure you can review the answers to these that are listed here on this slide. And this concludes the lecture that's on the renal content.